Okay, hi everyone. I want to go ahead and introduce myself. I am Montrez Lucas, the Associate Director of Patient Navigation here at NephCure. I've been here about 5 or 6 months, and I'm your host tonight for tonight's webinar, which is on genetic testing for rare kidney disease. We have an amazing presentation for you by Dr. Joshua Zaritsky. I will be introducing him, and from there, he will share his screen and take over as our presenter, and we'll leave a few minutes at the end for any questions that any of you all may have regarding his presentation or any questions you may have about genetic testing in general, and hopefully we'll be able to go ahead and answer those and get you some feedback. So I'll start out by introducing Dr. Zaritsky. Dr. Joshua Zaritsky is a pediatric nephrologist who has been in practice for over 15 years. He received his medical and PhD degree from Stanford University School of Medicine and did his fellowship in pediatric nephrology at UCLA. He is currently a pediatric nephrologist at Phoenix Children's Hospital in Phoenix, Arizona. He has a history of basic and clinical research in iron metabolism. Dr. Zaritsky has recently focused on the treatment of rare renal diseases such as XLH, HPP, FSGS, cystinosis, cystinuria, and BBS. So introducing Dr. Zaritsky.
Thank you very much. Do you want me to put I can't put my video on. It looks like you have to, and you have to let me do screen sharing also.
Sure, I'll go ahead and do that. I'm going to make you host so you can do it, okay?
Okay. Okay, let me share my screen. Good evening, everybody. Thank you for the very kind introduction. Turn my video on.
Dr. Zaritsky, you may want to go ahead. You may have to admit the people, the remaining attendees to panelists, the ones that are joining.
One step at a time here. Let's see, turn on my video. I got that. How do I admit people?
Just look to the right of your screen and you see a list of attendees and participants. You're going to go to the participants that log and just click on right click them and promote them to panelists, and they'll get a request.
So I go to I see. Oh, so go to the attendees and make them allow. I allow that. Huh?
Yeah.
Promote to panelists. Okay, I see what you're saying.
And that just go down the row and they'll get a request and they should be able to just allow themselves, and then they'll join as they join.
Boy, a lot of responsibility here.
You're doing great.
Oh, did I get everybody over?
They'll as they say yes, they'll move over.
Oh, okay. Oh, I think, and then let me go here. Can everybody see my? All right. Screen share is paused. I get back. Okay. Oh, resume share. Okay. Okay. Can everybody see my screen now? Everybody see everything?
Yeah. I can see it.
I get it. Oh,
we're off to a strong start.
Yeah, exactly. Thank you very much for the kind introduction again. And we're going to talk about genetic testing in rare kidney disease. You know, I'll start off just by letting you guys know that we had our, at Phoenix Children's today, we had sort of our review of genetics. So now we do, like you can imagine, we all sit around to discuss patients. We still do sit around to discuss interesting biopsies. And now once a month, we sit around and discuss genetic testing results, which I think is amazing because, 5 years ago, we were not doing anything like that. So there's been a rapid utilization of genetic testing in pediatric nephrology. So we'll start with a case. And this is a case of steroid-resistant nephrotic syndrome. Basically, a 1.5-year-old female who presented with sudden onset of nephrotic syndrome, which includes proteinuria, edema, and a low serum albumin, was placed on standard therapy, which is steroids, and there was no clinical response. And the biopsy was performed and revealed focal segmental glomerulosclerosis, usually associated with a steroid-resistant nephrotic syndrome. So talking about FSGS, it's one of these diseases. If you could pick one disease, if you asked me one disease that I'd ask to get rid of, it would be FSGS. And the reasons are here, basically. The biggest part is that it's a descriptive disease. We really don't understand, what is causing the disease. And because that, we have a difficult time treating it. We've finally come to realize that it's a podocytopathy, and I don't have enough time to go into that exactly today, but I'll show you how genetic testing has revealed that. And sometimes the cure for FSGS is worse than the disease. There's a high recurrence rate. And this just shows you that FSGS is the primary or the single line item cause of end-stage renal disease in children. And it's increased dramatically over the last couple of years. FSGS is just like we make it out to be. It's basically that in this part of this is our normal filter unit or colander of the kidney that filters the blood. In FSGS, we just see a pattern where part of this filter unit becomes scarred down. And we think it's due to the loss of these particular cells called podocytes. And that will make more sense in a second. When we talk about FSGS, especially if there's some adult patients on the line or some people who have family members with FSGS, there's really a large spectrum of disease that's included in FSGS. We have some people who just have overfiltration or overuse of their filter units. And then over here, the majority of the cases we think are due to an immunological attack. Something's attacking, the body's attacking these podocytes. And we're not so sure why. Here in the middle are these genetic forms of FSGS that have just popped up over the last maybe 15 years. And although they're exceedingly rare, they've led us to really help to understand the basic pathogenesis of the disease. I will remind you that one of the difficult things about FSGS, and this is one of these very fancy diagrams that nephrologists like to come up with, I'm just as guilty as other nephrologists. Although we come up with these fancy diagrams, the treatment of FSGS is entirely empiric. Entirely. We just try one drug after another looking for response. And unfortunately, with all these treatments that we have, the red indicates we're not able to put the patient in remission. You see how many patients, how hard it is to treat FSGS. Like this patient, this 1.5-year-old female had. So going back, the first sort of glimpse we had into really being able to understand FSGS really popped up when we were able to start to utilize newer technologies to do genetic testing. And this was one of the first tests that was available, I'll say commercially. It was available in England and they were willing to take cash. And this was the first time we as clinicians had the ability to basically send a sample out for a patient that had FSGS and at least look for a genetic cause of the disease, And what we've seen since then is that as the years go by, genetic testing is getting less and less expensive. So this is just a graph to show you that if you wanted to sequence the entire human genome, every gene in a human, it used to cost, look at this, $100 million, right? Even if you go back to that point, about to 2007, maybe it had a drop tenfold, but look at this dramatic drop since, right? And I can almost guarantee you it's below $1,000 now to sequence the whole genome. This orange line here is just this Moore's law, which sort of predicts, for computer chips, how they get cheaper and cheaper over time. And you can see that genetic testing has dropped dramatically off this curve. It's stabilized some. I mean, there's some basic costs associated with reagents, et cetera, but we have been able to take advantage of this new technology and leverage it thanks to the subsequent decrease in costs. So, and I'll just let you know is that, we used to argue what causes FSGS. We understood that if we looked microscopically at the filter unit, the glomerulus, we used to see an endothelial cell layer. We saw this glomerular basement membrane. And we saw these cells sitting on top called podocytes. We slowly got to realize that every genetic cause of FSGS was due to a genetic problem. And we'll talk more about genes in a second in the podocyte. And so essentially, we were then able to turn around and say, well, if these genetic causes lead to FSGS and they're in podocytes, FSGS as itself, as a disease itself, must be a podocytopathy. It's not necessarily a disease of the glomerular basement membrane. We'll talk a little bit about that's not entirely true, or the endothelium, but it's more a disease of the podocyte. The podocyte. So if we could somehow just protect the podocyte, we could prevent FSGS from developing. So let's go back to the case. Our patient, just because of the patient's age, actually had a sample sent to England. It was $800 cash at the time. And we found a mutation in one of the genes in the podocytes. And this is a mutation called WT1. And this one genetic finding had a lot of implications. We realized at that point that the patient had something called Denny's-Drass syndrome, which is generally a triad of 3 diseases, but it's a disease of progressive kidney disease that often, you can see almost all patients will go on to develop a kidney tumor. So we at that point realized this is a genetic cause of the disease. It doesn't make sense to continue down all this empiric therapy that we know is going to be largely ineffective. And we did a bilateral nephrectomy because of the risk of Wilm tumor. The patient was placed on hemodialysis and then soonly underwent successful renal transplantation. So this was going back to 2012, nearly 10 years ago. This was one of the first examples where we were able to tailor treat this patient. That is, offer this precision medicine or individualized medicine as opposed to just empirically treating the patient with FSGS. Find a reason for the patient to have the disease, this WT1 mutation, and then go on and successfully treat the patient. And this next slide might seem confusing, and we'll talk about genes, but what we're coming to realize is that you can see different changes in genes in different places. And that might seem overwhelming, but we're starting to realize is that by knowing the patient's where the patient's changes in their gene, we can predict their outcome. Scientifically, and I'll go over this again, we talk about the genome, or how their genes look, translating into what we call a phenotype, how the patient reacts, what happens to the patient. And as we do more and more genetic testing, we're able to better understand or predict how one particular mutation results in a particular phenotype. Oh, I might have gotten ahead of myself there. Now we're going to take a step back. If we look at any person and any cell, within the cell, sort of the basic building block of all of our tissues and organs, there's a place called the nucleus. It's sort of what you could think of as the control center of the cell. And within the nucleus, we have chromosomes, right? We have 23 pairs of chromosomes. You can think of that 23andMe, that's all been drilled into us. And each chromosome is made up of DNA. And if we could look all the way down to the level on the DNA encodes information that's responsible for genes. These genes then make proteins. There's the gene and the sort of the language of life there. A very kind of simplistic way, but effective way to think about your genes is you can think of them as a set of blueprints. If you were going to build a house, you would need a set of blueprints to know the office goes here, the toilet goes here, this is going to be a living room, we need to put plumbing here. And the genes, it turns out, we inherit 2 sets of blueprints when our body is built. We inherit a set of blueprints from our father and another from our mother. These 2 sets of blueprints are then used, the genes in these blueprints are then used to build our bodies. What can be complicated here, before I get there, I'm one step ahead of myself as usual. Talking about the genes and blueprints, you can imagine that sometimes when you go to build the house, you only need a correct set of blueprints. In other parts of the house, you need both sets to be correct. Okay, and that results in different patterns of inheritance. In addition, if I go out and maybe I burn a little hole in the blueprint and I make an error in that blueprint, not every error in the blueprint is going to result in a change in the house. Some errors will, some errors won't. And we're still in this kind of active learning stage about how blueprints, the genetic code that we are each given, lead to the house being built correctly. I will tell you that we're also at an age where even if we can find an error in the blueprints, some of the more novel treatments are being directed to directly fix the blueprint and the error in it. I hope that makes sense and that you can stick with that analogy. So remember, your genes, and we inherit are your blueprints for building your house. We get one from our father, one from our mother, and errors in these blueprints can result in errors in the house. Not every single error results in an error in the body or the house. And what we see is that there's several different inheritance patterns that we can see with genetic kidney disease. It's not necessarily important that you understand this at this point. It isn't. But remember how I was saying some genetic defects, right? When the body goes to build something, even if one blueprint is missing something, you can read off the other. Those typically are lumped into autosomal recessive diseases, the PPOD Mendelian genetics. Sometimes you need two correct sets to read and build the house. And even if there's an error in one set, that still causes an error. X-linked just refers to basically one set of blueprints determines your sex. And sometimes we see different inheritance patterns based on whether a mother and father have a boy or a female. And we really don't have enough time to get into that right now. But we now know, looking at adults at least, looking at large group, we recognize that about a quarter of people with chronic kidney disease, that is a decrement in their renal function, have a family history of some kidney disease. If we look at adults, we know roughly that about 1 in 10 adults who are diagnosed with chronic kidney disease will have a genetic cause. The next two slides we're still learning about, but we think about 1 in 5 children diagnosed with CKD will have a genetic cause. And then if we look at patients who go on to have severe chronic kidney disease, that have end-stage renal disease, that end up needing dialysis or a transplant, we think it's roughly about 2 in 5 children. We're still learning as we go along. And as we're able to basically better analyze the patient's blueprints, we're able to sometimes ascribe some of the errors in the blueprints to what's happened to the kidney. All right. So the beautiful thing about genetics, right, is that we can use it in so many different ways. For example, in the one case we talked about, right, the 1.5-year-old female who had FSGS, we were able to identify, right, the underlying cause of her renal disease. We knew it was due to an error in the blueprint, right? We weren't, able to deliver a targeted therapy. I'll talk more about these later, but we were better able to manage her by saying we don't have a treatment for this other than removing the 2 kidneys and putting her on the transplant, right? Does that make sense? You'll see there's some other things we can do. We can help to prescribe some precision medicines. We'll talk about that. The eligibility for clinical trials, we'll talk about quite a bit, right? And then it's also important to basically be able to test for other family members. And what I find a lot of times in pediatrics is I'm the one with the time to spend with the child to do the genetic testing to figure out. Then I'm able to go back and ask and look at the rest of the family and say, do you have a family history of kidney disease? And if they do, often I'm able to ascribe a cause. So there's been several families where the adults haven't known why they've had kidney disease. They have a child with kidney disease, and I'm able to kind of go backwards, go up the family tree, so to speak. And that's what we do as pediatricians. We end up taking care of the whole family. And this just shows you that this New England Journal of Medicine, where they basically they looked at 3,000 patients with chronic kidney disease, looked at their blueprints, looked at their genes, and found roughly 10% had an error. But with those errors, they were then able to turn around and say, we were able to change the clinical management of those patients in 89% of the patients. It's impressive. So one of the natural questions that comes up is, how do you know if genetic testing is right for you or a family member? And, part of the reason we've been able to offer genetic testing is because of the amazing drop in costs and the new technologies that are involved. So these are some of the questions you have to ask yourself, or ask if you have a family member, to say, hey, is genetic testing appropriate? If we had gone back 15 years from now, it was prohibitively expensive, and we really weren't able to get all the answers with it. Now with new techniques, we're able to ask and answer a lot more questions. So these are some of the questions. You can see here, do you have a known family history of kidney disease? That makes sense, right? That there's some error in the blueprint that's been passed on. Another important thing is sometimes if you or your patient, your child has sort of a mysterious disease, has the cause of the kidney disease been known? Has it been found out? And that's where genetic testing can help. Some other questions here for you to look at. So let's move forward with another case. Okay. This was a very interesting case I took care of around the same time back in 2012. It was a 10-year-old male who had presented with nephrotic range proteinuria. He had been treated empirically with prednisone. He underwent a biopsy where we actually, put the patient under, take a little piece of the kidney. It was non-diagnostic. And after 3 months of giving steroids, we thought, well, it's not making a difference. The patient still has protein, not affecting his life. The biopsy was non-diagnostic. Let's wait. And over the next 2 years, because the family could not afford genetic testing, they couldn't afford the $800 that was out of cash then. We waited until cheaper forms of genetic testing came along. And in fact, that first family actually helped us to develop a panel of genes that cause FSGS. And we were actually able to, this was one of the first patients we ended up testing. And this patient, ironically, was found to have a completely benign form of proteinuria. And that's due to a gene in a specific, a gene that, or a blueprint, an error in the blueprint that encodes a protein that allows the kidney to absorb any albumin or protein that's spilled over through the filter unit. And this is sort of an unusual presentation of this gene because only part of the gene's been affected, but a mutation in this gene, and both blueprints had been affected, so he didn't have a proper functioning tubulin. He just spilled a certain amount of protein, which I, as the physician, said, well, that's no good. You have proteinuria. That's something we need to treat. However, in this particular case of proteinuria, it does not lead to kidney disease. And this just shows you that, where the errors can be found in this particular part of the blueprint. And you can imagine that, let's say you have a blueprint that encodes for a certain part of let's say it encodes for the kitchen door, right? Sometimes you're missing the whole part of the blueprint. You don't have the kitchen door. Other times, you only have half the kitchen door. So the kitchen door maybe works. It keeps the dog out of the kitchen, for example. That's what we're talking about when we look for a particular error in a gene. What's amazing about this particular error in cubulin is that when we look over patients who have cubulin mutations, these blue dots up here, and here, this is just an indication of the renal function, they maintain normal renal function over time, whereas patients without cubulin mutations lose their kidney function over time. So I was able to go back to this family and say, you know what? I got you worried over the proteinuria for no good reason. Your son is going to do just great. He's going to follow this curve for his life. And so this is the idea that the genetic testing spared him immunosuppressive therapy that was never going to work or was ever needed. All right. And then finally, I'll let you know that, in nephrology, when I was a fellow, we learned about some very specific genetic causes. One of them was genetic diseases. One of them was something called a PAX2 mutation. And essentially, that was one of the first diseases studied, and it included a defect in the eye known as a coloboma and kidney disease. And we really thought we understood that if there was an error in this gene, it led to both the eye problem and the kidney problem. That was based on our old data. What we found as we started to look at more and more patients is that the phenotype, or what we expected to see from the patient for the PAX2 mutation, doesn't always result in the same phenotype. And in fact, this was a 10-year-old a male with a history of severe FSGS. He was on hemodialysis, unfortunately. The transplant center wanted to do a bilateral nephrectomy, right? They wanted to take out both his original kidneys because they were worried that if we transplanted him with just regular old FSGS, it could recur. They wanted to know when it happened. However, we did the genetic testing, ended up having a PAX2 mutation. And this was a shock for me because I had always learned that, well, a PAX2 mutation, you have a renal coloboma and you have kidney disease. And we can look at all these mutations here. Well, it turns out that not every mutation in PAX2 leads to that. And in fact, now we come to realize is that PAX2 mutations can lead to steroid-resistant nephrotic syndrome and or FSGS. And in fact, this was the case in this patient. And what was beautiful about this case is we could then go back to the transplant center and say, one, he doesn't need the bilateral nephrectomy. That would be an unnecessary surgery. And two, because he has a genetic cause, the chances of having recurrent disease is extremely low because we're going to give him a kidney that does not have that genetic disease built into it. Oh, right. In fact, when you look at patients who have steroid-resistant nephrotic syndrome, right, that means they've undergone every single treatment that we know and they still do not respond. We think up to 30% of those cases, right, that's an enriched population, can have a genetic cause of kidney disease, of their steroid-resistant nephrotic syndrome. That is the patients that we've already gone through all that empiric treatment, right? Now, if we study that group, we find that we find a list of genes that can help explain. And you can see the younger you are, the more likely we are able to find a causative genetic mutation. And that later on in life, although it's, overall, we can say 30%, it sort of drops down later on because we have more of these immunologic FSGSs happening here. Okay. So another why would you want to get genetic testing? And the amazing thing is that genetic testing is it's opened the door for new treatments. And I could spend the whole next hour talking about this one particular mutation, which, and sometimes we name mutations differently. Sometimes we call them polymorphisms, where there's a slight change in the blueprint. And we're not so sure how that slight change alters the house or something in the house. One of them is this APOL1 polymorphism. And we recognize that in African Americans, they have a higher rate of kidney disease, and almost their entire higher rate of kidney disease can be ascribed to mutations in APOL1. And, for a while, okay, well, we can identify who's at risk, but now we actually have a way, someone has figured out a way to actually block the gene product of APOL1. And this was just published in maybe 2 weeks ago, showing that that patients who have this abnormal APOL1 gene can actually be treated with this novel drug and actually have less protein in their urine. So this is the idea that if I can, you might say, well, okay, I have a genetic cause. Well, it's in the genes. There's nothing I can do. That's not true. About 50% of genetic diseases can be treated. And this is the perfect example. And I can tell you, this disease, we couldn't find an effective treatment until we identified the cause. And the cause, what was the cause identified? Was by genetics. So that is what is so amazing about, this is happening right now. And then finally, yet another why, and this was included earlier on, is to say, well, as we develop more and more novel treatments and trials for FSGS and other rare kidney diseases, the people doing the trial want a very uniform subject population, right? They want to show that their treatment is effective. And the way to do that is really to have a very uniform group of patients. And the way to do that is to look for genetic diagnosis. So increasingly, we're seeing the testing companies who do genetic testing pair a patient who has a particular fault in their blueprint or genetic defect with a drug trial. And it's really the true classic win-win-win, where the patient gets the treatment they need sooner than they would have without genetic testing. Because we're able to put more patients into trials, we're able to get trials completed sooner. And then finally, novel treatments are able to come to market, that we're able to produce new treatments thanks to genetics. So it's really an amazing phase. I'm going to briefly talk about one particular set of genetic testing. And a lot of times what we use now is we don't go after a single gene, but instead we do a little swab of your cheek, send it in, and they look at a panel of genes. This happens to be one panel. I'm a little biased because I like this panel. There's another panel made by the company Invitae. So, and I want to make sure I present sort of a balanced presentation here, that, I'm not saying one panel is better than the other. And I'm pretty sure if you go back to your doc, they can use either or. There's some advantages to one. And the one I'm just the most familiar with is the Natera. But what's happened over the years, thanks to that really drop off in cost, is that genetic testing, which used to be the last thing you do, now can be one of the first things you do. And Renasight is one of those panels that looks at 385 genes that lead to kidney disease. Now, what's so amazing about Renasight is that it's very inexpensive. If you have government insurance, if you have Medicare, Medicaid, TRICARE, Renasight is completely free. There's no out-of-pocket expenses for the patient or the family. If you have commercial insurance, they'll look at your out-pocket costs, right? And if it exceeds the maximum cash price, which is $349, they call you and say, hey, what are the alternatives? And they actually have a set of guidelines. So, like when I was told recently in the patient's eye test, the average copay ended up being like $15, right? And I'm not here to tell you, Renasight's the best thing since sliced bread, even though I believe that. You could say the same thing for Invitae. But what's so amazing is to think about a test that would have been prohibitively expensive in the past is now basically free if you have governmental insurance, or even if $349, that's not a bad cash price to pay for such an advanced test. And most patients with insurance are going to pay a lot less than that, a lot less. I will also tell you, and I know we talked about what slides to include here and how much Renasight stuff to do. And like I said, I feel a little, I do talk for Natera, so I have a little bias toward Renasight. I mean, I think it's one of those things that led to such dramatic improvement in care for my patients. It's like, I have to always pull myself back a little bit. But the company itself, and Invitae does the same thing, offers a lot of services to make getting genetic testing as easy as possible for the patient. They even include, for example, genetic counseling before and after, meaning if we do find something, there's a certified genetic counselor who's going to step you through and explain what we found. And that's great. Some of the smaller hospitals out there, they don't have access to genetic counseling. So this is a nice kind of bonus in getting a test. Oh, wait. Did I run through it too quickly? Probably, but we'll have plenty of times for questions. So just as a summary, our understanding of all rare diseases has increased tremendously in the last decade due to low cost, high throughput genetic testing. And it's almost amazing that, sometimes you think about the stuff around you, would you have predicted, I would have like, a folding phone or something like that. I would never have predicted that genetic testing would have gotten this available and this inexpensive. And like I said, when we were sitting around in our conference today, I was just amazed that we were having a conference talking about genetic testing results, whereas 5 years ago, that would have been unheard of. The other nice thing is we're seeing advances in both diagnosis, and then what we see is by making a diagnosis, we're able to develop novel treatments, and we're able to test the novel treatments thanks to genetic testing. And I would say, I gave you that list of 10 things when to consider. I would say, I'm not here to give you specific medical advice, but when in doubt, you need to consider the utility of genetic testing. That is, getting that additional information can sometimes be life-changing. So I think that's it. And now we have time for questions.
Thank you so much, Dr. Zaritsky. Does anyone have any questions? I'm sure we'll at least have a few. Okay. Martin, have you had any experience with IgAN patients? And if you do, what kind of treatment they're used?
So, with IgA, we haven't really been able to break in with genetics. We haven't found the genetic cause of IgA nephropathy. Now that might change in the future. I will say though, as far as rare diseases in kidneys, we finally have a new treatment for IgA nephropathy, which was just approved in February, a product called sparsentan. And we actually, that preceded, and I don't always call it new, but there's actually a gut steroid that you can take that's also been available. So IgA can be tricky. IgA is also sort of a disease that in pediatrics, we are it's a little easier to treat than in adults. So I think you need to, get yourself to a doctor who feels comfortable treating IgA, but you'll see we have at least 2 new treatments recently for IgA. It's very exciting to have.
Thank you. Next question is from David. Any suggestions on finding genetic causes to CKD where there's a strong family history, but does not appear in any of the known mutations? Sequencing new mutations seems tricky.
Yeah. So this is a very interesting question in that we realize that, we don't fully understand how we use the blueprint to build the house. And we don't really understand when we see an error in the house, we think there should be a genetic cause of it. and we go back and look and we can't find it in the blueprint. So you're exactly right. Finding new mutations, finding the new ones can be difficult. But the beautiful thing about this high throughput is that we are now able to really rapidly look for novel mutations in genes we knew about and in some genes we did not know about. So, and you also have to realize that sometimes, the blueprints, tell you, well, you need a part of this from a part of this, and we find that it's several genes that come together to make the final protein. So it's very easy for me to describe a defect in one single gene. We feel like some of the genes, like what controls high cholesterol, is probably a bunch of genes coming together, and that's probably the same thing for chronic kidney disease. But even the amazing thing is that we're able to, in adults, identify 1 in 10 patients, have a genetic cause. Our hope is as we get better and better, we'll be able to ascribe more of them to genetics. Now, clearly, some of the diseases are out there are acquired.
Okay. Next question is from Julie. If I did genetic testing in the past, should I do it again?
That's a good question. I would probably say if you had genetic testing done something like 10 years ago, it's probably worth getting it done again. Okay. Some companies will update their reports as they go along. So if they find a new mutation, or they'll amend their report. But probably, and I'm just throwing this out here because I'm not supposed to give you any specific medical advice. I would seriously talk to your doctor, your healthcare provider, if it's been more than 10 years. You might, for some of the other, if you were tested on a panel that had less than the 300 whatever, roughly 400 genes, it might be worthwhile doing it again if you can add those additional tests. Like if we go back, if we go back to 2012, I was so excited about a panel that had 37 genes on it, right? That cost $800 cash on the table. Fast forward 10 years, right? Now I'm looking at a test that basically does at least 10 more fold genes, right? And for most of my patients, it's free.
That's
so
amazing.
Who would have thought we had, in just 10 short years, we've come all that way?
That's amazing. That's incredible. Who interprets the genetic test? Is it the doctor or the genetic company? And does that make a difference?
Yeah, genetics is complicated, and there's no question about it. And a lot of times what we used to do is have to send the patient, if we were concerned about a genetic cause, we'd send them to a group of doctors known as geneticists, sort of the specialists in the blueprint of the body. Nowadays, because genetic testing is so much more common, we send less and less patients to the geneticist. So to make the diagnosis, we rely on interpretation by the company, and that's done in a very sort of standardized way, right? The company has a database of known mutations. So they compare the patient's genotype to what they know. Often they're able to ascribe, and with some degree of certainty, that this is a known mutation, they've seen it before in patients, and that's what the patient has. Other times we see these kind of errors that we're not so sure of. Those are called variants, meaning changes of unknown significance. There's the shorthand term is VUS. Sometimes then the doctor and the genetic company have to get together and find if those variants make a difference. And that was the perfect example when we had our genetic conference today, where our group sat down with a genetic counselor from Natera and said, hey, let's look at these mutations. Could we ascribe this mutation to a particular gene? The more and more testing we get, the more and more we're able to easily interpret the results.
Okay. Next question is from Cassie. Curious, did the benign proteinuria patient have symptoms, swelling, or low albumin?
He definitely had a slightly low albumin, it wasn't like a full-blown nephrotic, and maybe some slight swelling. My eye is affected. Once I see protein in the urine, I'm looking very carefully at the patient. And that was one of the things with the patient that, even before I did the genetic testing, we realized, well, nothing's happening with the steroids. Let's stop. Let's stop. And clearly this patient was different than some of the other patients out there. But of course, I had several lengthy conversations with the mom saying, proteinuria leads to renal disease leads to proteinuria. Although his course was seemed benign, I was worried that 20, 30 years from now, he would lose his kidneys to this disease, And, you try to prepare patients for that. You can imagine a mother hearing that or looking up what does proteinuria mean. So we had it was quite of a shock to her when I came to her and said, you know what, he really doesn't need any medicines because this is a benign cause of proteinuria. She actually, I'd spent 2 years telling her proteinuria is bad. She actually went to another hospital to get a second opinion, and they were able to say, "Oh, Dr. Zaritsky's right in this case. The cubulin is a mutation that's benign." But it was an amazing thing that went, it went full circle. Oh, wait, next question.
I wanted to, sorry, Jenny, I didn't see your question initially. So, Jenny has a bit of a comment. You can give feedback to that, Dr. Zaritsky. Jenny says, interestingly enough, my 10-year-old daughter just received a kidney on Tuesday. She has FSGS and, right, congratulations, Jenny. She has FSGS and did have a genetic variation of the PAX2 gene. Recurrence is something I worry about, but it sounds like I may not need to be as worried.
I think that, in all things in medicine, we can never give you 100% certainty, right? But when we find a genetic cause of FSGS, we worry about 100-fold less about recurrence. So if it's truly an autosomal dominant PAX2 mutation that's been identified, the chances of recurrent disease is exceedingly low. We worry about FSGS, there's a 30% chance of recurrence. Now we drop it down. It's probably not, unheard of, or it's not impossible to have recurrence. It's just so unlikely that everybody can just stop worrying about it.
Next question is from David. When you mentioned that whole genome tests are now available for under 1,000, did you mean the exome, 98% of genes, not a full genome scan?
That's a good question. I don't know the full answer to that. And that data there was probably referring to, what we call, what is it, the WES, where we sequence everything in the genome. So as opposed to an exome where we're just looking at what we call the encoding regions of the gene, we look at everything scanned. The ironic thing is, even though the cost has come down, it's like, drinking out of a fire hose. The real costs come in the man hours and the computing to figure out, what we find, is it real or not? This the shebang where they do introns and exons and the whole. So what they actually, what a lot of the companies do is they do a whole genomes. They do an exome scan. They do the whole exome scan, and then they just look at a panel of 35 genes, 350 genes. Does that make sense? But it has become, I guess the $1,000 is meant to compare it to the 100 million when we went back and sequenced the first genome of a human. So you can see how many orders of magnitude that costs have dropped. That doesn't, I think part of the tricky thing about genetics is, like, we don't fully understand. We think we understand how a blueprint leads to the building of a house, but we're not 100% sure. We're still learning stuff about how a particular error in the blueprint leads to. And then sometimes we see, parts of the blueprint that you would say, well, this part of the blueprint really talks about the lawn, has nothing to do with the house. And then when we look carefully, we find that an error in that part of the blueprint does affect the house somehow. And we don't always fully understand that. So we recognize that some of the coding, some of the errors in coding regions that are not part of the protein can still lead to problems with the protein production, the protein translation. I don't know if that was a great answer. That's where you need the genetic counselor. I think that one, that David's question, I think, would be better answered by genetic counselor.
Okay. And also, Jamie, hi, Jamie. 2 of our young adult sons were diagnosed with FSGS due to APOL1 in the last 2 years. Should our other children get genetic testing? My other children are nervous and torn on whether or not to get genetic testing, but she thinks that they're just scared.
Yeah, I think this is an excellent question because there's two parts of the question really. One is just because you have the APOL1 polymorphism or genetic changes doesn't mean you're going to go on to develop kidney disease. And we don't fully understand. We think you you definitely have an increased risk of developing kidney disease, but not everybody with the polymorphisms are going to go on to develop kidney disease. So, do you want to know about something that may or may not cause kidney disease? And that's a difficult question to wrestle with. However, that New England paper that I just showed you, this company called Vertex, is making something to treat these patients. So my feeling is that the sooner you know, the better you'll be taken care of by your nephrologist, your family doctor, looking for signs of the kidney disease, right? And then now, even if you develop kidney disease, there's a treatment that's going to come down the line in the next couple of years.
Mhm.
So it gets difficult when you talk about diseases like Huntington's disease that we really don't have a treatment for. It's almost like having a death sentence after age 50. Do you want to be tested for that? Do you want that, knowing the burden of it? APOL1's a little bit different because just because you have the APOL1 polymorphisms doesn't mean you're going to go on to develop kidney disease. And now, like I said, with this new treatment, I don't know, the future is extremely bright. And I wonder, I don't have basis to say this, but I wonder if, this increased risk we saw of kidney disease with African Americans with this new APOL1 treatment, are we going to eliminate that? And that's all thanks to genetics. That's
Yeah.
all thanks to genetics. So, I can't give you a specific answer to that, but I think that's the perfect question to go talk to your doctor about, right?
Sure.
Let's say your doctor uses Natera. He or she can direct you to the genetic counselor ahead of time to say, hey, let's have a conversation about what we could find, right? And so you can even get the support before doing the test. So as opposed to hearing me yammer on about should your children get genetic testing, have them talk to the genetic counselor. I will tell you with any type of testing, sometimes when we go to look at a result, right? We find a result that we weren't expecting. Right? Or we find something that's non-diagnostic. And that's also something important to talk with your doctor ahead of time and talk with a genetic counselor.
Thank you. The next one is Martin. He says he's in Latham.
Latin America, probably, I'm guessing.
Oh, sorry. Forgive me, you all. It's a little late here in Atlanta. Can I be tested from here if I send the sample? If you don't mind, Dr. Zaritsky, I'll try to answer that. So before we end the webinar, I will put in not only my name, my title with NephCure, as well as my NephCure email address, because I do actually refer patients to Natera who do want genetic testing. And we do have a contact there that makes it pretty easy. I send the information over. So I'm pretty sure that you can, Martin, but I will put my email information and my name and everything in the chat so everyone can see it and take it down so that we can follow up via email if you'd like to as well, and I can help you navigate that process.
Oh, look at that. Look at that. So there's Jamie saying my son is in the Vertex study, so we're very grateful, right? And that's to me, that is the perfect the promise of genetic testing, right? To get into the study, right, you have to have the genetics, and then you get the treatment very early on, and Vertex is able to get the study done very quickly.
That's amazing, Jamie. Anyone else? So I want to make sure everybody able to see that my email address there so that you all can reach out to me. So we also have a connection as well with geneticists that are at Columbia University. And so if you want to follow up with that as well, as Dr. Zaritsky stated in a previous answer, that there are some questions that they probably may be able to answer as well. If you all would like to follow up with any questions for Dr. Zaritsky or for me to connect you with any genetic testing that's available, I am more than willing. So please feel free to reach out at any time. That's my email address. I usually answer all patients and everyone in the community within 24 hours. So I'm pretty quick to respond. So please feel free to reach out to me at any time with any questions, and I can shoot them over to Dr. Zaritsky or help you navigate the whole process with genetic testing. Okay. Does anyone else have any questions for Dr. Zaritsky at all? You're welcome, Cassie. Okay. Well, Dr. Zaritsky, that was incredible. Thank you.
My pleasure.
With
My
me
pleasure.
throughout that. That was so informative and amazing. We also recorded this, so if you all pretty sure our team will make it available. So please feel free to reach out to me. As I said, my email is there, and I will follow up with you as quick as possible. Thank you all for joining tonight or this evening.